all the memory of rainy afternoons, swingy Harlem tunes, motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine, the personal and moments on the Hudson River line.
Just the last name of the day of birth.
How lovely it was.
Okay, or sends them away. No, we love your concerts. I'm also on call, so if the phone rings, you all are going to help me answer the questions. Okay? So, we are going to, you guys heard from Dr. Blodgett over there already, and you just heard from Dr. Lucy. Those two people are experts in diabetology. You have heard from the best. So guess what my job is? To make sure you were listening. So my job is going to be to quiz you. Okay? So I'm going to need your help for most of this talk. Okay, they apparently can't find mine. Oh, there it is. They put their little thing on there. Okay, wait, we gotta change this. Okay, this is my timer so I don't mess up your break. Or maybe getting out of here early. Okay, so can you advance for me? So that I can rove? Oh, he's gonna make me do it. Okay. All right, so you've already learned this. Our population, those over 65, some of us are approaching that quickly. Over 25% of our population who's over 65 has diabetes. Most of them will have had it during their middle age. But some people will acquire it after age 65. Does anybody, okay, what's the Gpp trial? What was that?
Diabetes prevention.
You cannot answer these questions. You guys are good. That is right, the Diabetes Prevention Project. Did they have older adults in there? Yes. 20% were over age 60. How did they do? What was the Diabetes Prevention Project? It looked at lifestyle modification versus what? Metformin. You guys are good. Okay, so those who were over age 60, the 20% of them, how did they do with lifestyle and how did they do with metformin? Which worked better?
Lifestyle.
You guys are beautiful. Lifestyle. How did the metformin work? Not in the older people. Believe it or not, it was not as good in the older group at preventing diabetes. Lifestyle was the way to go. And lifestyle actually worked better for the older patients than it did for the younger ones. And the older patients did not seem to have a benefit from metformin. Interesting, right? Okay. You guys have already learned this. The problem with older patients and diabetes is the risk of hypoglycemia. Look at that. Twice the number of patients over the age of 75 are going to be in the ER for hypoglycemia. What does that do to your brain?
Kill cells.
Not good. Cells die. Do you think people who are older feel it as early? No. Their blood sugars have to be even lower for them to feel it. So hypoglycemia in the elderly is really a problem because they don't feel it as early, and when they do have it, they kill brain cells, and they don't come back fully. Huge problem. All right. So the Dcct trials and the Ukpds, these were my trials when I was growing up. When I was a fellow, this was all the rage. Who were the diabetics enrolled in the Dcct trial? Type 1 or type 2s? They were type 1s. Who were the diabetics enrolled in the Ukpds? Type 2s. What were they looking at for these two trials? Why did they come up with these trials? What did they want to know?
The tighter the control, the more complications you can prevent.
You're beautiful. We were treating all these people with insulin, and everybody goes, well, are we doing any good? And is lower actually better? We didn't know if tight control was good. It was the Dcct trial and the Ukpds that were the revolutionary trials that said, yes, tight control can prevent what? Microvascular complications. Did these trials say anything about macrovascular complications? No. However, they looked back they looked back later at this group. And how long did these studies go on? They went on about 10 years. 10 years they tightly controlled these people. And then these people were released from the study. Guess how their control was compared to their cohorts? It was all about the same after that. Okay? It took a lot of work to keep them tightly controlled. However, what did they find out about macrovascular disease in the patients who were tightly controlled for the first 10 years, and the diabetics in the Dcct trial and the Ukpds trial had just early onset diabetes? What did they find out when they looked back 20, 30 years later? They had fewer heart disease. They had less heart events. Nothing about stroke. Nobody's ever shown that tight control of diabetes does anything for stroke. But they did look back on this group, and the ones that had early tight control did have fewer cardiac events. Interesting, right? Because what are the three big studies that we just talked about? Well, you guys talked about, I think, with Dr. Blodgett and Dr. Lucy. What are the three big new studies about cardiovascular disease and diabetes and tight control? What are those three studies we're all supposed to know? What just revolutionized the way we manage diabetes? There are three top trials. Yes, the Accord, the Advance. What's the third?
VADT.
The VADT trial. And what did those trials, what were they trying to do?
Show cardiovascular disease.
So the Accord, the Advance, and the VADT trials, they looked at patients with type 2 diabetes who'd had diabetes now for how long? 10 to 20 years. Not newly diagnosed, but they'd had diabetes for 10 to 20 years. And they said, we're going to tightly control them. And we're going to see if we can prevent heart disease. What did they find? What did they find in these three trials? Did we prevent heart disease? No. Which trial was stopped early? The Accord. And why was it stopped early? From what? From, they believe, heart disease. But what else may it have been? Because some of these deaths were sudden death. Louder.
Hypoglycemia.
Yeah. So the Accord trial was stopped early because there were more deaths in the people that were being tightly controlled. The Advance, there was not an increase in cardiovascular events, but there was not a decrease. And they did see some sudden deaths that they did not know what it was from exactly. And the same with the VADT trial, okay? So how do we reconcile the differences between the fact that in the Ukpds and the Dcct trial, they had fewer cardiovascular events versus these folks? What's the difference that I mentioned? Bingo. Who was treated early? Yeah. So in the Dcct trial and the Ukpds trial, these were younger people that had newly onset diabetes, and that's when they started their tight control. The problem with the people that were in these trials is what? They were older and they'd had their diabetes for years. And a lot of them already had cardiovascular disease. That's the difference. Very good. That's the difference. So in type 2 patients with cardiovascular disease or a long duration of diabetes, they may be harmed by tight control. But young people with new onset diabetes, that's where you get after them. Those are the people we need to tightly control. Okay? All right, and I think you guys already saw this, and Dr. Moosey did a beautiful job of saying, hey, when you're talking about older patients, you got to think about them individually. Are they healthy? Is their life expectancy long or short? And adjust your goals accordingly. And all of this information in this table was put out after they looked at the data from the Accord, the Advance, and the VADT trial. Because remember, not only did they look at type glycemic control, they were looking at blood pressure goals, and they were looking at lipid quality as well. Is that me or you?
Yeah.
At least somebody's about to weigh in.
Veto.
Okay. So, let's start with our first case.
Tell them to mute their phone. Say, somebody mute, unmute, because they're listening to you.
remote.
It's remote.
Hey, they want you to shut off the remote.
Thank you.
Awesome, thanks. Okay, that's better. I feel better. Okay, so this is a 75-year-old female. When I was just got to Program Medical Center, I was prior military. This was one of my first diabetics when I got it. And I followed her for years. So she's 75 and she has type 1 diabetes. Yeah. And she had it since age 20. She was on insulin pump therapy. And she had done pretty well, but she had some microvascular complications. And she had some AFib, and unfortunately she did have some hypoglycemic unawareness. And she had some coronary artery disease. And so at this point, she's eligible, right? Uh-oh, battery. Can you guys turn off the mic? The remote mic? Hello? Hello? You guys want to answer the question? Okay, so I think we're there again. All right, so do you keep her on the pump? Do you take her off the pump? Ooh, I like this gal up front. She's whispering all my answers.
So she's been on a pump for 40 years. She was like on the very original pumps.
Oh, that's interesting. She donated her, she had one of these big pumps, one of the very first models, and she donated it to a museum. She is very familiar with pumps. She's the cutest little lady. She's so cute. Okay, so I want you to think about that. All right, next slide. Oh, I got to do it myself. You want Okay, how does glucose get into your system?
What you eat.
Yeah, what we eat. Where else? How come you don't die at night when you're not
Liver.
Okay, anywhere else? There's one other place it kind of comes from. Nope, not the pancreas. Keep going. You're close. You're in the vicinity. We eat it. Oh, who said it? No, some. Yeah, louder.
Kidney.
Kidney. So the kidney, you can get some blood sugar from your kidney. Yes. So you ingest it, or you can get it from the breakdown of glycogen stores, and the liver has the biggest supply of glycogen, but your kidneys also have some glycogen. We've all seen it, right? Who has the worst hypoglycemia unawareness? Liver disease and kidney disease patients. Okay. And you can generate sugar from the liver and a little bit from the kidney. Okay, let's all agree the main player is going to be the liver, right? Okay. This is all to help us talk about type 1 and type 2, the pathogenesis. Okay. Insulin, where's it made? Pancreas, which cells? What else is made with insulin in the beta cell? Packaged with it? That's the islet cell. That's the name for the beta cell. Beautiful. What's packaged with insulin is secreted with insulin. Which cells make glucagon? Beautiful. Alpha cells. Excellent. But what is packaged with the insulin from the beta cell? Okay, keep thinking about that. All right, so insulin is a 51 amino acid peptide, and it comes from the beta cells, and the beta cells are on the inside. They're the inside ones. Remember, there's alpha, beta, PP cells, and D cells, right? What do delta cells make? Anybody know? Delta cells. Barb? You don't know? You know everything. Oh, I go to her for my questions. Okay, somatostatin. Yeah, they make your somatostatin. Remember, somatostatin inhibits everything. Somatostatin is just an inhibitor of everything. Okay, what does the PP cells make? Pancreatic polypeptide, which is becoming kind of popular. We'll talk about that in a little bit. Okay, so insulin is is made by the beta cell. It's packaged with C-peptide, co-secreted with C-peptide, and one other thing called amylin. Anybody hear about amylin? We're going to talk about that. Okay. So what are the effects of insulin on fats and protein metabolism and glucose? You have to have insulin to get glucose into which cells, which organs?
Muscles.
Muscle and
Uh,
muscle and Juan, take a stab.
As well as brain.
Your brain does not have to have insulin to use the glucose, believe it or not. It has its own little transporters. Liver, actually, you can transport the glucose into the liver cells, but insulin really is helpful. And insulin is important in the liver. But the main ones that absolutely cannot get glucose into them without the insulin, so we said, what's the other one? Fat. Very good. That's what we were waiting for. Okay. So you got to have insulin to get the glucose into the fat and the muscle. And insulin prevents muscle and fat from being broken down, right? Helps you build up stores. It's an anabolic hormone. Brrr. You get big. Okay. I'm going to tell you a story on how you can remember that insulin is an anabolic steroid. So I have to deal with adolescent diabetics who have type 1. That means they make no insulin, right? I have my guys and I have my girls. Do the girls like to take their insulin? Why? Because they gain weight. So my girls are horribly controlled. What about my guys? In fact, I had one guy, he was a football player, and what did he have? Severe hypoglycemia all the time. Why? If he took a lot of insulin, he could build a lot of muscle. He figured that out. And he would take so much insulin that he would make himself repeatedly hypoglycemic. Insulin is an anabolic hormone. Okay. So insulin's going to inhibit the breakdown of glucose or glycogen to glucose. You don't need it, right? You got insulin, glucose is going into the cells. It's going to inhibit the breakdown of glucose, and it's going to help you store glucose. And you don't need to make new glucose, so it's going to inhibit gluconeogenesis. Okay, in the fat cells, it's going to keep the triglycerides from going out of the fat. It's going to keep the body from making free fatty acids, and it's going to keep the body from making ketones, right? So, if you have poorly controlled diabetes, what lipid fraction is going to be elevated? Triglycerides, right. And if you don't have enough insulin, what else are you going to possibly make? Ketones, yes. Okay, good. So glucagon. Glucagon is becoming very important. We tend to kind of, we've ignored it previously, but it's becoming very, very important. Glucagon does really the opposite of insulin, right? It's a catabolic hormone. What does glucagon help you do? Break down glucose, the glycogen stores, gets glucose into your system. What do we give our type 1 diabetics to their family members to give the patient if they get low blood sugar? Glucagon, because we know that that's going to raise the blood sugar up fast. And where's it getting this sugar from? The liver, the kidney. The glycogen stores in the liver are going to be broken down by glucagon. Gluconeogenesis is going to occur, okay? So, which cells make the glucagon? Which cells?
Oh, the alpha.
The alpha, yeah, and they're more on the outside. Okay, so my lady, she has what type of diabetes? So what does that mean? By definition, what does that mean? She has to have insulin to survive because what's wrong in type 1? They don't have beta cells. Why don't they have beta cells? It's an autoimmune phenomenon. And usually, if you measure them early, the patients will have positive antibodies. There's a few that won't. So, for type 1 diabetes, there's usually a genetic predisposition. There's some environmental trigger. Their body starts making antibodies, and they start destroying their beta cells. Okay, so they have plenty of glucose around, but they can't use it. Why? Because they have no insulin. They cannot get it into the fat and the muscles. Starvation in the midst of plenty. There's tons of blood sugar around. They can't utilize it. Okay, so here is the definition. The presence of autoantibodies, early onset, and immediate insulin requirement. And usually we see this in young patients. Okay? We're starting to see it older. Now remember, our type 1s who got it as kids, just like my lady, are living to older ages. So we are going to have to be cognizant of what type of diabetes our older patients have. You cannot treat a type 1 like a type 2. Know which type of diabetes they have. Okay. So how do we treat type 1s? Insulin, 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 insulin. We're going to give them basal bolus therapy. They got to be on both short and long acting, and these are the doses that we use it. Usually we want them on about 50% long acting and 50% short acting before their meals, right? You can do this with shots, or you can do it with an insulin pump. And if they've been on an insulin pump for a long time, whoever set it up here, they know what they're doing. Leave them alone. It'll be worse to change it to shots. Yeah, and that would get devastating for this lady. I don't think she'd given herself a shot in 40 years. If you're going to, remember pens. Switch everybody to a pen. It used to be a nightmare in the VA. It's much easier now. It's much easier. Switch those older patients to pens. It's so much easier to dial it up, and I know Dr. Rogers talked to you about that. Okay, what else? What else is available to treat type 1s? Is there anything else that's approved for the treatment of type 1 diabetes? Anything?
In addition to insulin?
Okay, I'll give you now.
Like
Other
Similac?
forms? Oh, you're good. Say it loud.
Similac?
What is similar?
It,
What's packaged together with insulin?
The C-peptides.
Not the C-peptide. What was the other thing I said? Amylin. So amylin is Similac. That's exactly right. And what does Similac do? It is actually, amylin is approved for the use in both type 1 and type 2. It's the only other thing besides insulin that's approved. Are you going to use amylin or Similac in an older type 2? Should I put my little lady on that? Oh. She's saying you're crazy if you do that. Why would you not do that?
It causes hypoglycemia.
Yes, the amylin has, yes! Oh, I love it. She's looking at me like, you're crazy. Because that lady has hypoglycemic unawareness. And amylin has been associated with higher incidence of hypoglycemia. It's not a good idea for our older patients, right? But that is something that's out there. So, insulin is the mainstay. And I put this slide up here because on the top is normal human insulin. And on the bottom is all the differences in the analogs insulins that we're using. The more unlike normal insulin you are, the longer you last. Look at Detamir. It's got that weird carbon moiety on it. Just weird. So the more unlike human insulin you are, the longer you hang around, and the more like human insulin you are, the faster acting you are. So Aspart, Lispro, do you know what the difference is between our normal insulin that our beta cells make and Aspart? What is it? Just one base pair. That's right. They switched the Aspart for Dr. Blodgett. I can't remember.
I think it's
Alanine.
Alanine for the
Licepro's easier because what did they switch it? Lysine 4A. They call it Licepro. Yes, isn't that cool? I just love that name. So I thought they did a great job naming it. So the more like human insulin you are, the faster acting you are. The more unlike, the longer acting. Okay. So here's another slide of all those fun long-acting insulins. Okay, Dagludec. Anybody heard of that? You have? Oh, you work with Dr. Tripathi? No. Okay. So Dr. Tripathi is doing some research and he's used some Dagludec. There are going to be a lot of new insulins coming around. Dagludec is supposed to be a long-acting insulin. It's supposed to last 48 hours. It did not get approval the first time it went through. I can't remember why now. Do you know why?
Because they were worried about hypoglycemia, that it might, when they switched, that it caused more hypoglycemia.
Yeah, I'd be worried about that too, especially if it's 48 hours. So how many old people are here like me? What was that old insulin we used to use that used to supposedly have ultra lente? It was supposed to have a half-life of like 72 hours. And I never knew how to use it. I was like, I just don't even know when to dose the next one. So I don't know. I don't know if I would know how to use these long-acting insulins. But just be aware that they're out there. And you may see some of your patients on them. Okay. I don't want to go over, so let's make sure. We good?
Yes.
Okay. Afreeza. It's this new inhaled insulin. Yeah! Okay, there are two pictures. The picture on the bottom, what's that? No, you two. Okay, what is it? Oh, she does do research, because that's all, it just really pretty much stayed in the research world. What, can you imagine carrying that thing around? Yet, no.
You have all of non-compliance with that.
Yeah, and so it never caught on. It was not popular. Yeah, so this is the cute little new one up at the top.
That's cool.
Yeah, that's a Afreeza, looks like a little bird whistle. What's the problem with these? I really had trouble when Exubera came out. I couldn't prescribe it to my patients. Why? What was I worried about?
Do they know how, well, number one, do they have any pulmonary problems, but do they know how to use it?
Yeah,
Will
well,
they use
yeah.
it correctly? Will they use it, dose themselves
Yeah,
correctly?
but terrifying to think about causing lung problems.
Yeah.
I mean, I really just can't get on board with it, so I'm going to let somebody else be a guinea pig. But when you're telling me I got to have baseline pulmonary function tests, that's pretty terrifying.
And then there's that hypoglycemia.
Yeah, with any insulin you can have hypoglycemia. I think I less worried about the hypoglycemia than I am about all the lung stuff. So, believe it or not, the VA, they're carrying this stuff. Yeah, let me show you. Let me show you what they said. Okay, so this is the VA's recommendations. They said, okay, if they've got lung disease, don't do it. Okay, I'm on board with that. Oh, there's our friends again. Okay. You got to have diabetes that requires insulin. So it is approved for both type 1 and type 2. But the VA says, oh, you can only use this if you are on, if you have severe local reactions to injections, or you can't use needles in the workplace. I don't know where that is.
They work in jail.
Oh, that's an interesting thought about the truck drivers. Yeah. You're supposed to be on basal insulin with this, but maybe. And then I have one patient who has a psychological aversion to needles. But again, they're supposed to be on basal insulin with this. So I'm not sure how this is going to work. I'm just not sure. So it's called Afreeza. It's cute. Remember, the old one was Exubera, never caught on, but we'll see. Okay, so type 1 and type 2. Here's the insulin pumps. Dr. Blodgett is the pro. She has been doing insulin pumps for a long time. She's the expert. But for my lady, she was on a Medtronic for years and years. Do you know which one? There's a Medtronic, and then there's one called the Omnipod. So you see the two pictures? One is the Omnipod, and my young people like it. Guess which one it is? Is it the one on the top or the one on the bottom? Yeah, because they're not attached to the little meter. The Omnipod is just a reservoir of insulin, and it communicates with the device that's not attached to you. So the young people tend to like that. Okay, so insulin pumps are great for type 1s. Great. We love them. And if you've got an older patient who's computer savvy or been on a pump, I think they're great. And Dr. Blodgett, yeah, she's on board. Okay. So, we do also have something that we like for type 1s and anybody with hypoglycemic unawareness, and these are just continuous glucose monitors. The Omnipod does not come with a built-in continuous glucose monitor, but they can get a Dexcom to use with it, and that's a continuously sensing your blood sugars every 5 minutes, and you can get a live readout. So you know if your blood sugars are going up, if your blood sugars are going down. Unfortunately, my 75-year-old patient that I had years ago, she died, but I would have given her one of these, or I would have gotten her on a Medtronic pump, that had the built-in continuous
Would
glucose
have helped
monitor.
her, given her.
Would
insulin
have helped her,
awareness. I
yes.
mean, hypoglycemia.
Prevent that, yeah. Okay,
So
so we
Medicare is not paying for them, is my understanding.
I think they are if you have type 1 and you have hypoglycemic awareness. And the
Okay.
VA, we are covering these like mad.
Ah.
Yeah, we're doing a good job. Type 1 with hypoglycemic awareness. But you know, the type 1s who get pumps, they come with it anyway. So you can get it. All right, if you give them the Medtronic, because it's built in. Okay, have you heard about this? So this is the new thing that's going to be available, they say 2018. Did you guys, the bionic pancreas. What's different about this? You have 2 meters, or 2 monitors here. For the Medtronic, I just had one, right? You just had one. So the insulin pumps use what? Insulin, right?
Right. So one for insulin, one for glucagon?
Beautiful! Can you say that again? That's fantastic.
One for insulin, well, I'm an RN, but I've never heard of this. I'm just trying to think.
Yeah!
Okay, one for insulin and one for glucagon.
Yes, that is the new wave. Because what are these type 1s missing? A lot of them, especially when they get older, they're missing the glucagon as well. Or we can give them a little insulin, give them a little glucagon as their blood sugars are tightly being controlled. It's just brilliant, right? And you have a continuous glucose sensor, and it's infusing your glucagon and your insulin as you need it to keep your blood sugars steady. Yeah, it's exciting. What's that? How do you carry it? So unfortunately, you're going to have 2, one for your glucagon, one for your insulin. But they're working, they'll probably have one that you wear with a little reservoir of both. But those are all the things they're working on right now. But they've tried it. Guess who they've tried it in?
Young people that have already.
Young
used the other
people?
kind.
Yeah, young
And
people.
they're very happy to try that.
Yes, they are. So they've done it in young people and older adults, but not old adults. So these are adults that are way less than 50. Kids, way less than 50. Yeah, and I'm going to show you some data. It's really exciting. Okay. Okay, guess which guy is the guy who invented this bionic pancreas?
Oh, they wanted the middle one on the bar, flat shirt.
The guy that's not holding one of the bionic pancreas meters. It's the guy in the plaid shirt. He's from MIT. I know. I thought he was one of the people that was doing it. Young guy, right? Okay. Cool. Okay. On the far left, see all those circles? Those are the blood sugars not on the bionic pancreas. Yeah, you see the wide spread? And the sugars on the far right for each of the groups? Yeah, tight control without severe hyper or hypoglycemia. That is cool, right? So 2018, maybe we'll have one available. So that was published in the New England Journal in 2014. And again, you can see they did adolescents and young adults. Yes?
What study, remember earlier how you were referring to a study where you said that they had tight control and they had to drop the study because people were dying because they were controlled too tightly?
Yeah, that was the Accord. Those were old people.
So really then, if this is going to control really good, you're not really going to want to use this in older people because you're going to control their things too well, right?
Yeah, except the caveat for that is,
Okay.
what do we think may have been the huge problem with tightly controlling those hypoglycemia? So if we can learn that that was the real problem, and we don't get any of it with this, with tight control, maybe. Maybe, but you're right. This is not going to be for type 2s, and we're not going to want to put it on old people.
Yeah.
We'll start with the kids and those young adults. But it's exciting, isn't it? Yeah, so you're right. I'm not going to give a bionic pancreas to my 75-year-old lady. Okay. All right. So we talked about amylin. Thank you. And what are we going to do? Not give it to our older patients. And plus, it's an injection. They're already giving themselves injections. Okay. All right. So I left her on a pump. So let's talk about this case, and I need you to be aware of these guys. This is a 56-year-old female that we see at the VA. She's got a picture all over the place. She's got B12 deficiency, hypothyroidism, and diabetes mellitus for a couple of years. She was doing horribly on oral agents. She did okay for a little while, and then just horrible, and she ended up in DKA. I think she ended up in DKA a couple of times. And they said, oh, let's get her to endocrine. What type of diabetes does she have? Take a look at her weight. she's a little overweight, but not much. She's pretty thin, right? What kind of diabetes does she have? What?
Check a GAD on her, find out for sure.
Yeah.
What kind of diabetes does she have? Any takers for type 2? Any takers for type 1? You guys are more right than the other people. Okay, so what's the other category? It's called LADA, right? What does LADA stand for?
Latent adult onset diabetes.
Very good. Latent autoimmune diabetes in the adults. And which antibodies, if you're going to pick one to measure, might still be positive in these patients? The GAGs. The glucamic acid decarboxylase. Those are the ones that are going to hang around a while. And if you have somebody like this, they're thin, they have wide range in their blood sugars, where they've been in decay. Think about this. Do they behave more like a type 1 or a type 2? Type 1. How should you treat them? Like a type 1 or a type 2? Type 1. These guys need insulin. And that's what we did with her. We put her on basal bolus insulin, and she's doing great. She hasn't had any more decay. She's doing fantastic. Okay. LADA. Oh, sorry, decay, diabetic, ketoacidosis. And what drives that? They have no insulin, and the glucagon is there, and it's driving with ketones, and they go into decay because they need ketones to get fuel, because they can't use the glucose because they don't have any insulin, right? Okay, so diabetic ketoacidosis. All right, so that's LADA. You're going to treat them as a type 1. Okay. Now we'll see if you were listening to Dr. Blodgett and Dr. Rusin. 68-year-old man with LADA. He's on therapy with basal bolus insulin, and he wants to know if he would be a good candidate for this new thing called an SGLT2. Okay, what do they do? You guys talked about them. What do they do? How do they help lower your blood sugar? Right. So you dump any extra glucose into your urine. So whenever your blood sugar gets above about 180, you start spilling glucose. Well, these things work by taking mildly elevated blood sugars and dumping it into the urine, right? What do they take with it?
Calories.
Water. What can happen to you?
Dehydration.
Yes! Are these good for all older patients? No, these are terrible! Terrible! Okay, the other thing that's been out, that just came out with a box warning, and I did this. What are you not supposed to do? What else do these guys get? They get DKA. What's DKA?
Diabetic ketoacidosis.
So, who do you not give this to? Type 1s or LADAs. They're already predisposed to decay. And what they don't know is these things seem to be glucagon generators. They increase glucagon levels. We don't know how, we don't know why. And glucagon then can fuel the production of ketones. Okay, so don't give this to type 1s, don't give it to patients with LADA, and don't give it to older type 2s. Whoops. 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 Yeah. All right. Okay, good. Okay, so that's the story on SGLT2 inhibitors. You know, there's a familial, it's a genetic defect, where there's people who were walking around with extra glucose in their urine. And the way we used to screen, the old people here know, we used to screen for glucose in the urine. That's how we used to diagnose diabetes. So
I think your phone's
oh, that's just the alarm. Good, we don't have to answer any tough endocrine questions. Okay, so that means I've got how long?
15 minutes.
15. We're going to do 10. We're going to be done. Okay. So, this was found by a genetic syndrome. Patients have this defect genetically. Do they have diabetes?
No.
No! No! In fact, that's completely normal. What happened? How do we find it? People kept saying, oh, we think you have diabetes, you've got a lot of sugar in your urine. They're completely fine. But that's how they figured out. That's how they developed these SGLT2 inhibitors. Isn't that cool? Okay, and there's a couple now. that are available. They're great, they're oral, they cause weight loss, and they help blood pressure.
Was that person, that 68-year-old, would you normally put somebody with a lot of diuretic? Because almost all type 2s are on diuretic.
Well, she raises a good point, but he's not a type 2, he's a type 1.
He's a type 1, okay.
Yeah, I would use it for blood pressure, especially if his blood pressure's okay, it's a little
That's
bit.
another reason why you shouldn't put them
Yeah,
on.
but if he was a little tiny old thing, small, I'd be hesitant if I was worried about dehydration. But again, we don't want to put a lot on it because we're going to predispose them to decay. Yeah, so don't do that type 1s and Ys. Some of us did that. Okay, so the SGLT2 inhibitors, again, low risk of hypoglycemia. They're only going to do it if your blood sugar's high. Improvement in blood pressure. Why is that? Because they work like the diuretics, because it's going to cause a little volume depletion. Okay, and then you can read about all the disadvantages, and don't forget, there's a box warning now about decay. All right, so here's type 2, and you already know about type 2. Is everybody who's morbidly obese got diabetes?
No.
No, why?
Because their beta cells are able to keep up with
Their beta cells are fantastic. They haven't worn out. So you got to have two problems. Everybody who's obese is insulin resistant. But a lot of those obese patients have these fantastic beta cells that don't seem to wear out. And then there's some patients that are just mildly overweight. And their beta cells are worn out already. Yeah, so just depends on your beta cells. Hopefully you got good ones. Developing type 2 is stroke. Shoot. Post-stroke. Well, the problem with post-stroke patients is they're not going to be exercising. And so that may be a predisposing factor. Oh, yeah. So, you know, exercise, diet, and all that is really much more difficult after a stroke. So,
He's not overweight. He's going to be thin.
yeah. Be careful he's not a lot of. If there's not a lot of. But it could just be type 2 and he's not overweight. And for all those reasons, his beta cells just don't. Yeah, I'm not overweight, but guess what? It's in my veil. Type 2 diabetes. And we have crappy beta cells. All right. Okay, so type 2, you don't have an antibody, your beta cells still work, but they're not able to overcome your insulin resistance. I mean, the amount of insulin your beta cells have to put out for some of these patients, amazing. Amazing. All right? But once they can't do it, that's when you develop diabetes. Okay, so you got all these options. You got tons of options these days. What did I have when I was training? Insulin and sulfonylureas. I mean, we got a whole slew of great things. Okay, so we're just going to hit on a few more nuances and we're done. Okay, 67-year-old lady. Hypertension, hyperlipidemia, diabetes, osteoporosis. And now some CKD. She's on metformin, A1C is 8.3%, she's otherwise healthy, get a little on time, so we really want her to be a little bit better. And we're worried about the renal insufficiency, so they stopped her metformin. What's the new guidelines?
If it's
Let's go, less than 30, less than 30, what are you going to do?
You're going to stop it.
Yeah!
Yeah, you got to stop it.
Okay, less than 60?
You can use 1,000 milligrams per day.
All right, here we go.
If
Whoops.
yeah.
Here you go, on the bottom. These are the FDA packaging, right? And it was just based on creatinine. This is the FDA. That's the packaging on the FDA. Did the FDA change their packaging?
I would think so.
No.
No?
But does the VA support the differences? Yes. So, in Canada, in the UK, at Audie Murphy, after all these publications in the New England Journal and the JAMA, this is what they're recommending. So don't use less than 30. But actually, two at GFR are 45 to 60. You're still able to use up to 2,000. Ooh, I don't do it. I'm a little more conservative. Barb's over there. Oh, you weenie.
Yeah.
Okay. 30 to 45, you got to get it down to 1,000. All right? So you can do this. I always worry that it's going to change faster than I can follow, so I'm a little more conservative. But remember, the FDA did not change their packaging. Okay? All right. Thiazolidine diners. So let's go back to the case for a second. What medicine are you not going to use and why? What other medicine are you not going to use and why? Okay, so maybe if you want, you can keep her on metformin. What other medicine are you not going to give her that is okay for renal function? What else is okay for renal function? Thiazolidine diodes are good. How about the DPP-4s? They're okay. How about the GLP-1 agonists? Depends. Less than 30, no. But you can use some of them in some renal insufficiency. So we got the thiazolidine diodes, DPP-4s, GLP-1 agonists. Which one of those are you not going to use and why?
She has osteoporosis.
Thank you. Which one? Oh, you're good. You are all on track. Which one? Can anybody help her? My research person. Which one of those has been shown at this facility, thank you, Dr. Tripathi and Dr. Bruder, to worsen osteoporosis? And you need to think about that, especially your older women. Any guesses?
Lactose?
Actose, pioglitazone. Yes. Yes. Excellent. All right, so pio. Don't use pio. All right. Case 4. Okay, this one's easy. Oh, that's the same one. Thanks, Barbara.
She has HS.
So good. Okay, so we have another one, 68-year-old, unable to tolerate metformin, on a fixed income, extremely worried about copays. Luckily, that's not here, but it is sort of here. What do we put all our patients on after or with metformin? Sulfonylureas. Okay, now I was in here when Dr. Musi had the slide up about sulfonylureas. We are talking about a 68-year-old lady. We're talking about older people. And you can't even do it in the PA. But which sulfonylurea should you not use? Glyburide. And it's not even available to you. Why? It hangs around a lot longer.
Yeah, it's very,
and there's
very
a
long
much
half-life.
higher risk of hypoglycemia. Just stick with glucoside if you're going to have to use these things. Okay. So, well, case 6. Is that the same one, right? No, this is a new one. 68-year-old lady, and she's on metformin. Good quality of life. Gonna live a while. 8.2%. We'd like to get her a little lower. So, what other options do you have? You have the thiazolidine diodes. Do I like those? Do you like those? No, Dr. Kathy and Dr. Elijah do, but I don't because they get edema, they get weight gain.
The dose
The Toza.
Yeah, so I'm a bigger fan of the GLP-1 agonists and the DPP-4s. What's the big difference between the two?
Weight loss for
Weight loss is dramatic for the GLP-1s, but what's the disadvantage of that one that our old patients may nausea, vomiting, they have to do an injection. So for our older patients, that might not be the way to go. What might be better? The DPP-4s, because they're oral, they're more mild, and maybe in some of our older patients we want to be careful about rapid weight loss. So good. All right. Do you guys know why the DPP or the GLP-1s work? Okay, so you see oral glucose and you see IV glucose, and you see the insulin curve. Why are they different? Why is the insulin level higher when you eat a meal? What are those things called? They're called incretins. So when you eat a meal, you release incretins from the gut. And what are incretins? GLP-1, CCK. So that's how they figured out, hey, these things will help increase insulin, they will slow gastric emptying, and they will make you less hungry. It was from these studies. So what was the first one to be made? By Ada, where did we make it? Where did it come from? Called the Gia, the Gila, the Gia monster. There you go, the saliva of the Gila monster. And it gets broken down rapidly. And so that's why you have to give it as an injection. In our bodies, what enzyme breaks down GLP-1? What enzyme breaks it down? DPP-4. So Januvia is a DPP-4 inhibitor, so you have more GLP-1 around. But again, with the DPP-4s, you don't get the weight loss, but the GI side effects are more mild, and it's oral. So there's the DPP-4. 4s. All right. So, I promise, and we're almost out of time, but this will be quick. Type 3 diabetes, what is it?
Type 1's with insulin resistance.
So type 1, what is type 1? No insulin, antibodies that are destroying your beta cells. Type 2, insulin resistance plus a defective beta cell. What is type 3? It's not actually type 3, it's type 3C. Do you see the criteria there? What's type 3C?
Genetic disease.
So it's diabetes that comes from pancreatic diseases, okay? All right, so type 3C is what you'll now read about. And it's from diabetes that's due to pancreatic problems. And it just has gotten popular because that is the classification from the ADA. So now everybody calls it type 3C. 3C. Yeah, that's all. Yeah, and there's no, yeah, it's crazy. And actually DeFranco doesn't call it that. Okay. So I had a patient, University Hospital 3 months ago. He's getting his pancreas removed because he had a huge mass. Luckily the mass was benign. What kind of diabetes is he going to have?
Type 3C.
Type 3C. How are you going to treat him?
Insulin.
Exactly. He's getting essentially his whole pancreas out. He is going to be brittle or easy to control? So brittle, because he really has no glucagon and he really has no insulin. So when he goes low, he is lacking any glucagon. So these patients that get their pancreas removed are a nightmare. But also be aware that there is more pancreatic disease in our population, and as patients get older, if they've had chronic pancreatitis, they're alcoholic, they may be more of a type 3C, and they may be somebody who needs insulin. Okay? So think about it. Just think, in the older patients, what's the cause? What's the cause? Okay, and here is a quick table at the end. Again, remember, type 1, we said it was co-secreted with C-peptide. So in type 1, when your islet cell is destroyed, you have no C-peptide. In type 2, your beta cell's still working, it's normal to high. And in type 3C, it's usually going to be absent. Insulin, low, low, depending on how much of your pancreas is destroyed. Glucagon, normal to elevated, normal to high, but again, over here, if you've had your own pancreas out, go on. And they're starting, remember I told you about the pancreatic polypeptide, which is made by the Gpp cells? Some people are starting to measure it to help us decide if there's pancreatic insufficiency. But that is not ready for prime time, don't do it yet. But maybe in the future. Okay. If you Google, that's what you'll find. And these people said Alzheimer's disease is like diabetes of the brain. They're the only ones. Dr. DeFranco laughed at me, Dr. Tripathy laughed at me, I'm sure Dr. Blodgett's laughing in her seat now. Okay, so that is not a type. That's the ADA endorses. All right, so we'll send that away. Okay, so the ABCs of diabetes in the older adult: adjust A1Cs for the patient, comorbidities, individualized therapy, incorporate patient preferences, and avoid polypharmacy. Be very aware of hypoglycemia, and please, please think about what type they have. What type they have. And think about pancreas. Do they have pancreatic disease? Because I don't think we think about that very much. And then, I used to be very good at this. I tried it once. Don't be the first one to put the patient on the redrug. Don't be the last one to take the patient off the redrug with Okay? All right. Very good. Thank you guys for participating. We're absolutely
Any questions?
Swingy hollow tubes, motor trips, burning lips, burning toast.
All right.
Dr.
Thanks,
Koops
guys.
has to leave and lobotomize someone. Everybody? Okay, ladies and gentlemen, we're going to take a 15-minute break until our next speaker, Merle Waltz, is in the building.
How lovely it was. Many's the time that we feasted, and many's the time that we fasted